So welcome back to part two of our look of um, embryogenesis and the development or sexual development of gonads. We started this conversation in the first video, and this will be the second of those videos. And today we're really going to be looking at and focusing on the influence of hormones on sexual development. So we've talked about the development of ovaries, and testes. We've talked about some of the external development of um, reproductive anatomy. Today we're going to be looking a little bit deeper into this. And so one of the things that we're going to be looking at is the story behind the differentiation in or between female and male brains, in addition to the gonadal organs or the sex organs. And so I promise you this will be a little bit shorter of a video than what video one was. But this is going to be just as interesting, so don't let its brevity fool you into thinking that we're not going to be having as much fun as we did in that first video. And so let's go ahead and jump into this and start looking at a couple of the things that we need to consider. And we're going to start with looking at what we refer to as regional masculinization. And so let me come in here. Hold on 1 second. And so again, when we talk about the male brain, what we're really referring to here is regional masculinization. And so it's important for me to note that there is no such thing as a fully male or a fully female brain, right? You've got the brain. But what we do notice during development is that through hormonal influence, and we're going to talk about this here in a few minutes, regions of the brain, segments of the brain can accumulate hormones to a greater degree than others. And this has an influence on their development, what we refer to as the masculinization or the regional masculinization of parts of the brain. And this regional masculinization does not only happen in the male brain, it can also happen within the female brain. Just like non-masculinization can happen in the male brain, as well as a brain within a female individual. So this is why we say there's not really a male and female brain. It is the brain that is then going to have hormonal concentrations exerted onto it regionally, right? Regionally. And so we know we have testosterone that is going to be one of the primary hormones that are going to be involved. And we know that in general gonadal development, the release of that testosterone is what is going to lead to the development of the testes, the scrotum, and penile development, right? But again, we also have this idea that it will cause or lead to masculinization of regions of the brain. And I'm gonna insert one little word in here, and that is the word indirectly. And so testosterone is going to indirectly cause masculinization of regions of the brain. And it does that by actually not directly causing that masculinization. Testosterone cannot cross the blood-brain barrier. And so it needs to be converted. And it needs to be converted into estradiol. So remember, yesterday or in the first video, we looked at that biosynthesis pathway for testosterone. And we know that testosterone can be converted into DHT, right? With 5-alpha reductase, or we saw that it could actually be converted into estrogen or estradiol by an enzyme called aromatase. And that's exactly what happens, right? Testosterone levels are starting to increase, and all of this testosterone is trying to get to where it needs to go. It can't cross the blood-brain barrier, so it gets converted by the enzyme aromatase, which ironically is secreted by fat cells, right, or adipose tissue. And so this aromatase is now going to drive the conversion of testosterone into estradiol or estrogen, and estrogen can cross the blood-brain barrier. And so it's actually a higher accumulation of estrogen within regions and segments of the brain that leads to this regional masculinization. It's not testosterone directly, it's estrogen, a hormone that we traditionally think of as only being a quote unquote, if you can see me doing my air quotes, female hormone. It's not. Males produce estrogen, females produce testosterone. It's almost a misnomer or a misrepresentation to consider testosterone only a male hormone and estrogen only a female hormone. We can see here that in males, right, that estrogen level is going to be elevated or heightened because of an elevated level of testosterone that is going to drive this regionalization or masculinized regionalization within the brain. And this happens during the critical period, which is between weeks 16 and 28. And that regional masculinization from the conversion of testosterone into estradiol or estrogen is permanent and irreversible. So those that influence, environmental influence, if you would, or hormonal influence on the brain during weeks 16 and 28 of fetal development is permanent and irreversible, right? And there's some interesting things here, right, to be considered. Right? One of those interesting things, at least one of the things I consider to be interesting here, is in female fetuses, their T levels are going to be much lower. It's not going to be non-existent, it's going to be lower, which means the conversion of testosterone from aromatase into the estradiols is also going to be lower. And that low concentration of estradiol that is being produced does not cross the blood-brain barrier. So in other words, the concentration of the estrogen is so low that it can't get into the brain to cause any kind of masculinization within the female fetus. And so this is why that masculinization, that regional masculinization, does not generally occur within a brain of a female individual, but it does happen within the brain of a male individual, unless, always remember, I've got two rules here, right? The first rule of biology is there's an exception to every rule. Second rule of biology is there's an exception to rule number one of the exception rule. And so there's always exceptions to this. And this is going to lead into a little bit broader of a conversation. But what if that female was over-secreting testosterone? Then they would have an elevated level of estrogen, and that concentration of estrogen may be high enough to be able to cross the blood-brain barrier. And within that brain of a female individual, you could have, again, air quotes going up, masculinization, regional masculinization within that brain. And think about what that might think about the impact or the effect that that might have on personality, sexuality, attraction, all these things, right? One of the reasons why we've discovered this is through the looking and the research done on rats. So Rats have estrogen that is produced through placental and ovarian production. And what ends up happening during pregnancy is this estrogen that's being produced by the mama rat from the placenta and the ovaries combines with a protein called alpha fetoprotein. It's called alpha. Sorry, that's my really bad alpha sign. Alpha fetoprotein. And this is a blood protein that binds to estrogen. It binds to estrogen. And when it binds to estrogen within the rats, it blocks estrogen from entering into the brain of the developing rat pups, into the rat fetuses. So it doesn't lead to that regional masculinization within the rats. We don't have, as humans, we don't have alpha fetoprotein. And so this is why we see that regulation happening through these means. In individuals that have brains in females, they're producing lower testosterone, and that testosterone is not being converted. So think of testosterone and think of aromatase being the analogous to alpha fetoprotein, right? In the sense that it's aromatase that is going to cleave the testosterone, more cleaving of testosterone, more estrogen, elevated estrogen crosses the blood-brain barrier. What's preventing the estrogen from crossing the blood-brain barrier in the rats is the binding of alpha fetoprotein to the estrogen. So that's keeping those estrogen levels really low. And so kind of an interesting understanding of how that brain develops and matures during the second and the third trimesters. And the notion that, that exposure to estrogen during week 16 to 28 is permanent and irreversible. We can't go back in after the fact and add more estrogen to try to masculinize maybe a brain in a male individual to try to go ahead and change personality or behavior. It doesn't work that way. It doesn't work that way. And so with that, let's continue this look at hormones. That's his brain, right? Now we've got some other things to consider here. And these are individuals that we would classify or deem as being intersex. And one of the other terms I'm going to throw out here to intersex is something that you might see in literature being DSD. Differences in sexual development. This is part of this is the premise behind sex and even sexuality in that sense being a spectrum characteristic. Just like everything else we've looked at in AMP1 and AMP2, all of these things are spectrum characteristics. They're spectrum traits. No other system functions as a product of a binary choice. Everything. The premise, the entire foundation of this course is homeostasis. Homeostasis is predicated on a spectrum of viability. You have a range of function. Right? That's the premise of homeostasis. That is a spectrum. Right? Why would sex all of a sudden violate every single other process within the body? It doesn't. It is a spectrum characteristic. It's a spectrum trait. When you look at sex development and sexuality from individual to individual to individual across a population, we see a spectrum of development and expression, just like everything else within the body. And so this does fit who we are as a species. Nothing tricky about this, right? Nothing tricky about this. So DSD, differences in sexual development, is another term that you will often see when looking at and discussing and researching intersex individuals. And so one of those is what we call ovotestis. And this is where you've got both a combination of seminiferous tubules and ovarian follicles. Now remember, seminiferous tubules and ovarian follicles are made from the same tissue. They're made from the medulla within that gonadal ridge. So that shouldn't be any surprise. And remember, the left side and the right side develop independent of one another. So in other words, just because the right side is developing doesn't mean that the left side is lockstep in queue. Right? There is individuality within their development. So you could have a circumstance where you have a seminiferous tubule on the right side and ovarian follicles on the left side. You could, depending on dispersion of receptors, have actually one gonadal structure that has both seminiferous tubules and ovarian follicles within it. Right? All of these are possibilities. And then you have morphic intersex individuals, which is where you usually have an ovary on one side and a testy on the other. So this is not the actual seminiferous tubule and follicles. These are the gonads themselves. You may have an ovary that has a Mullerian duct and a testy that has a Wolffian duct on one side or the other. Right? And again, what this emphasizes is something that we looked at the last video, and that is that development of gonadal tissue is localized and independent of left side and right side. Okay? Left side and right side. Now, what might cause this? There's some other things. Hormone receptors, hormone availability, left versus right. Cells that are producing testosterone could differ from left to right. But there's also even genetic control that is in here. In other words, there is a variant of sexual development called mosaicism, where some cells within your body may have an XX, other cells in your body may have an XY. And if these XY cells are, let's say, located on the right side during embryonic development, and maybe these XX cells are isolated on the left side, these XX cells are going to be expressed in DAX1 in a higher level. And so the left side may develop with an ovary, right, and the Mullerian ductwork. And the right side with its XY, that DAX1 gene is not going to be, it's going to be expressed, but not enough to inhibit the expression of the SARI gene and testis determining factor. And so on the right side, you could actually have the development of a testis and the Wolffian ducts or the mesonephric ducts that are then developing into gonadal anatomy. And so again, you've got a lot of variation in how this can be expressed. And so let's look at a few examples, right? Just a few examples. I'm not sure what's on this next side here. Okay, so some variations of intersex, right? So not all of it has to be internal. So you could have your gonads that are agreeing with the chromosome of sex. So you might have ovaries, and that might parlay and agree with your XX chromosomal status, but maybe the external genitalia doesn't develop as female external anatomy. Maybe it develops as male. Right? Or what typically happens is you've got testis on the inside, got testes, your XY genetically, but the external genitalia actually is that of a labia minora, labia majora, with a vagina and a clitoris instead of a penis. Right? This is very common. And in that case there, where you've got internal testes and an individual that is an XY chromosome, but develops external female anatomy is what we call testicular feminization syndrome. Now, I have an issue with pathologizing these individuals. Right? That term syndrome means somehow there's something wrong with you. Right? Somehow this is not normal. And we come to name this because of this inherent system of binariness that we've got when we look at sex and sexuality. And so if you're outside of the binary, you must not be normal. We're going to call it a syndrome. As we begin to understand more of the spectrum expression of sex and sexuality, you're going to start seeing that these are not going to be classified as syndromes, and instead, what you're going to start seeing more and more of is that term variation used. And so testicular feminization variant would be a more appropriate term to use that. And again, this is where you've got normal testes, undescended, they're inside, and you've got XY chromosomes, but you have external female anatomy that will develop. And by the way, the reason why the ovary doesn't develop in this case is because the testes are still present and they are secreting. I don't think I mentioned this in the first video, but there is a substance called MIS. And MIS stands for Mullerian inhibiting substance. And this is something that is, this is an enzyme, this is a protein that is released from within the Sertoli cells. Right? So these are secreted from within the Sertoli cells of the testes. And so since you still have normal testes, you're producing this Mullerian inhibiting substance, which is essentially dissolving or reabsorbing the paramesonephric or Mullerian ductwork. But due to an issue typically with receptors, the rest of the anatomy does not develop within this. And so what does a individual that has testicular feminization variant look like? Well, this here is an individual that is has testicular feminization variation. So if you look at this individual, you would swear up and down that this is a female. But in all reality, if you were to do a scan, an x-ray, or even any kind of other imaging, CAT scan of this person's abdominal area, you would actually see two testes that are inside that area. And if you did a chromosomal test, this individual would be XY. And so genetically they are male. Gonadally they are male, but external characteristics, they are female. Right? And again, to look at them, you would not know that they are intersex, but they are. And I think this is some of the complexities that we need to think about as a society, especially for those going into the healthcare field. In how do you approach treatment for intersex individuals, which is about 3% of the population. Now, we're approaching 8 billion people worldwide. 3% of 8 billion is not a small number. It is not a small number. I can guarantee we have intersex individuals on campus. You would never know. You would never know. But if you're going into the healthcare field, you're going to encounter them. And you need to be able to go ahead and respond to them in a humanistic, sympathetic, and yet professional manner. And not treat them as if they are somehow inferior, less than, imperfect, damaged, not normal, so to speak, right? And so think about that, right? Think about the implications of the healthcare field that we have with this. And so this is one example. Another example is Gevidosis. Right now with Gevidosis, it literally translates into penis at 12. And you can see down here, this is an individual here that was diagnosed, if you would, with Gevidosis. And this is a variant, intersex variant, that is most common to the Dominican Republic, to the DR, but it is not isolated to the DR. This is a global variant on sexual development. And what ends up happening within individuals that have gevodosis is they are female at birth. Right? Now, remember, we assign sex by looking at genitalia. Right? And so we literally look between the legs when you're born and we say, oh, yep, that looks like it's a male. Oh, yep, that looks like a female. And so these individuals, doctor would take a peek. Oh, yep, okay, that's a female. Very good. Excellent. But then in and around puberty, in and around age 12, what ends up happening here is testosterone levels begin to surge. And the challenge with this is the reason why male anatomy does not develop, male external anatomy does not develop during embryo and fetal development is because the body is lacking that 5-alpha reductase enzyme that we talked about in the last video. And so no 5-alpha reductase means testosterone cannot be converted into DHT. And we know that DHT is the hormone that drives external male anatomy development. And so no DHT, no penis development, no scrotum, right? No spongy urethra that develops. You're going to develop a labia minora, labia majora, and a vagina, even though internally you've actually got testes. So what ends up happening? How does this switch happen? Because at age 12, right here, all of a sudden, testosterone levels start to increase. And they rise so heavy, so high, because of the onset of puberty, that it actually forces the development of the secondary sex characteristics associated with the male. So the clitoris begins to enlarge and develops into a penis. The labia minora begins to fuse and forming that spongy urethra. And the labia majora ends up closing up and fusing, forming the scrotum, which then allows the testes to descend. And so you spend the first 11, 12, 13 years living your life as a girl, and then all of a sudden, between ages 12, 13, on up to about 18, 19, 20 years old, you're undergoing this metamorphic change of that external anatomy. As a side note, this person is fertile. This person produces sperm. This person can go ahead and reproduce, have a normal sex life. Right? Not every encounter of sex is meant to lead to pregnancy. Right? In fact, one of the things that you'll hear me say very often is that sex is first a means of social bonding and secondarily a means of reproduction. So our primary focus or primary use of sex is not for reproduction. It's for social bonding. And so this person would be able to have sexual activity, sexual engagement, whether it was for social bonding and networking or whether it was for reproductive purposes. But they grow up and spend the rest of their life completely normal. Another example that we have is what we call adrenogenital syndrome. And with adrenal genital syndrome, patients are genetically female, they've got ovaries, but you have an over-masculinization of the external anatomy. And so the clitoris is enlarged. It's enlarged to the point that it looks like a penis. Right? And you can see that right there. Right? It looks like a penis. You have the labia majora that actually fuses and looks like a scrotum. The labia minora fuses and actually kind of creates almost like a modified, it's not a true spongy urethra, but it's a modified spongy urethra. And so all of this is happening. And what ends up happening here, what causes this, is an inability of the adrenal gland to release the cortisol. Cortisol, we should know, is regulated from the anterior pituitary hormone, adrenocorticotropic hormone. And what happens with that under secretion of cortisol causes an overproduction then of testosterone within the female. And so remember, females, even during fetal development, can produce testosterone both in the ovary and within the adrenal gland. And this is where we see it's within the adrenal gland, that zona reticularis, where we see that overproduction of androgens or testosterone that's being produced. And it masculinizes, if you would, that external anatomy that is present. And you can see there what the changes are for that as well. I do want to spend just a few minutes on looking at intersex versus transgender, right? Because there is a difference. Not all intersex individuals undergo transgender treatment or therapy, right? And transgender are not intersex either. So there's that very distinct difference within that. And so we can see here I've listed some intersex variations, right? We talked about mosaicism. We talked a little bit about 5-alpha reductase. We've talked about ovotestis a little bit, and there's some other ones that are listed there that we did not talk about, but you're more than welcome to go ahead and take a look at that. And then you've got transgender, and there is biological basis for transgender, right? And so there we know that there are differences within the amygdala within the brain, which is part of the diencephalon. Regions of that express proteins differently in males that would then later identify as being transgender, and as well as females that would later be identify as transgender as well. They look different. So transgender males have a diencephalon, specifically that amygdala region, that is more similar to a female. And trans males have an amygdala that is more similar to that of a male brain. And so we can actually scan this. We can actually see this. We can stain it. Histologically, there is a difference there, right? And part of that then, that difference within the amygdala leads to a disconnect between how the brain perceives the individual that they are seeing within the mirror and anatomically what is being expressed. That person is feeling female but seeing male, and that causes them some level of distress, anxiety, frustration, depression. Right? Everybody that is transgender has different levels and different degrees by which this is all expressed, right? And so we refer to that disconnect between what the brain is processing and what the actual physical appearance is as being gender dysphoria, right? There is a loss or lack of phoria or acceptance. And the goal of any kind of trans bio healthcare or anything like that is to try to move that person from a feeling of dysphoria to euphoria, right? Or gender euphoria. And so what does that look like? Well, you have affirmation pathways, right? Everybody, again, responds differently. For some people, that gender dysphoria is not as severe, and just social affirmation is all they're looking for. Now, not all transgender individuals, it's not only transgender individuals that look for social affirmation. And so don't get that confused either, right? You've got various genders that also will look for social affirmation. And when we talk about social affirmation, we're talking about the use of pronouns. Right? But for some transgender individuals, just referring to the individual as they, them, or he, him, or she, her, is enough to send them into dysphoria, from dysphoria into euphoria. Okay? it would be a minor instance of transgenderism. Likewise, some people might need social affirmation and legal affirmation where they can actually change their name on a birth certificate or on their driver's license. Right? That dead name, right, that name that they were given at birth, and then they later changed it to refer to that as their dead name, is not who they identify as. And this is one of the reasons why in classes we typically ask, what name would you like to be called, right? What is your name? It might differ than what is actually on the legal paper that is in there. And so for some people, they need that legal affirmation. For some individuals, they might not need social affirmation necessarily. They might not need legal affirmation, but it might rise to the level of medical affirmation. Medical affirmation is reversible. This is hormone replacement therapy, right, or HRT. Now, HRT is not only used for transgender individuals. It's used to treat a wide range of, especially biological conditions. And so HRT gets a bad rap, especially I think nowadays, but understand that it's not only transgender individuals that are utilizing and benefiting from that hormone replacement therapy. And again, it is reversible. If an individual who is 12 years old, 13 years old, maybe has not started with full-blown puberty that is changing, stage 3, stage 4 of puberty, they undergo hormone replacement therapy. They can go ahead and if they, for whatever reason, if they decide to cease that hormone replacement therapy, financial, family pressure, religious reasons, societal pressures, laws, legal constraints, societal, whatever it might be, their body will go back to them producing whatever hormone set that they are supposed to be producing, and they will continue to develop. It's actually safer to do it that way than to allow that individual to undergo puberty, go through the development, which can lead to greater gender dysphoria, a higher instance of disconnect, depression, suicide, death, suicidal attempts, and all of these other things. Allowing them to undergo puberty is actually more damaging for some of these individuals. But they can undergo the hormone replacement therapy at that later time, and again, they can stop and it will revert. What is not reversible, what is more permanent, is surgical affirmation. And this is where you might have, if you're a female, you might have double mastectomy, where the breasts are removed and you have chest implants that are put in to look more masculine, right? You might have penile enlargement surgery that is done, where you surgically enlarge the clitoris. You might have where you reduce the size of the penis, and you go through a procedure where you actually form the vagina and kind of restructure, resculpt that of a clitoris. That's surgical affirmation. This is not a process of you move from social to legal to medical to surgical. Definitely medical to surgical, yes. But for some people, going through medical affirmation is the end of the journey. They're whole. They're good. For some people, surgical affirmation is needed. Surgical, both top surgery, bottom surgery, right? That's kind of the societal phrasing that is used. Many transgender individuals will elect to only maybe do top surgery. They never undergo genital removal. And so that surgical affirmation in that case there can be reversible in that sense. If they never undergo quote unquote bottom surgery and they only undergo top surgery. So there's a lot of complexity that is within this. But transgender is different than intersex. Intersex is different than transgender. They do cross. They very often, through scientific illiteracy or biological illiteracy, they do sometimes get lumped together. But they are different, very different. in the scope of um, development. Right? They are very, very, very different in that. I will also say that there is a WPATH, WPATH. It's a world organization. They do set the standard of care for transgender individuals. So there are very strict protocols that are in place that any doctor here in the United States would go ahead and recognize and follow as good medical care and practice and mental health care for their patients. I will just also kind of mention that the DSM. Right? So the DSM is the book used by the American Psychological Association (APA) for diagnosing and treating mental disabilities or disorders. The DSM back in 2012 removed gender identity disorder from the nomenclature, and it only recognizes gender dysphoria. And so gender identity disorder, if you would, is no longer a recognized mental condition that has treatment prescribed and identification of, right? But gender dysphoria does still remain, right? Being transgender is a gender identity. It's not a sexuality. Right? Keep that in mind. Right? Being transgender is a gender, not a sexuality. There is a difference between one's gender and one's sexuality. And so kind of keep that in mind, right? And again, I want to stress that not all trans individuals have to have all surgeries or have all of these affirmations met at any point in time. And with that said, guess what? This video is done. Next week, or your next series of videos, is actually going to be looking at the male and female gonadal anatomy and a little bit of reproductive biology. We're going to get into some reproductive biology with the ovarian cycle and the uterine cycle. And so these are going to be your last two main topics that we will be covering within the course. And with that, I will say my traditional and usual catch you on the flip side.